Hi everyone, my name is Med2Med. This is the second part of my videos on adrenal disease. This time we're going to be specifically looking into hyperaldosteronism and Phaeochromocytomas. If you want to recap other adrenal diseases like Cushing's and adrenal insufficiency, it might be worth going back to part 1. These notes are based on the following resources. I've been using Scott's Notes recently, a PDF with concise notes of everything you need to know for medicine on the wards. As always, I've been using the Oxford Handbook of Clinical Medicine and utilising the NICE guidelines. As a disclaimer, I am a third-year medical student. This video is not intended to be a substitute for any professional medical advice, and you should always consult your doctor about any health concerns. We've looked over this before in the last video, but let's have a quick recap. So what are the adrenal glands? Well, it's an endocrine organ. So remember, these are responsible for secreting hormones. This particular gland is found above the kidneys, as the word adrenal comes from Latin ad, meaning near, and renal, meaning kidney. We also now know that the adrenal glands are made up of the cortex and medulla, which both secrete their own type of hormones. The cortex is actually made up of 3 zones: the zona glomerulosa, which releases mineralocorticoids like aldosterone, the zona fasciculata, which releases glucocorticoids like cortisol, and the zona reticularis, which releases androgens like dihydroepiandrosterone. Then, separate to the cortex, as we've mentioned, you have this innermost layer, the medulla, which is responsible for secreting stress hormones such as adrenaline. So in hyperaldosteronism, there's a raise in aldosterone. So remember, this is made by the zona glomerulosa. In Phaeochromocytomas, there's a lot of catecholamines being made. So for instance, adrenaline. Let's look at primary aldosteronism first, which is where there is an excessive aldosterone production, which is independent of the renin-angiotensin system. We know that aldosterone is responsible for sodium and water retention, so this increases in this disease. As well as the majority of water and sodium is being reabsorbed in the proximal convoluted tubule. Now, because the body notices that there's a greater sodium and water retention, negative feedback occurs, and renin, which is usually responsible for triggering this release of aldosterone, is decreased. But because of this continued sodium and water reabsorption, which is independent from the renin, the patients become hypertensive. It also causes potassium excretion, hence hyperkalemia, and alkalosis. I hope you recognise this image. I just want to kind of solidify the information we've already gone over. So this is the processes that occurs during the activation of the renin-angiotensin-aldosterone system. We know that in primary hyperaldosteronism that it is independent of renin, but instead is caused by an increased aldosterone, which you can see here causes the sodium reabsorption, potassium excretion, and water retention. I actually have a lecture all about hyper and hypokalemia, which is worth checking out if you're not familiar with how to recognise and treat both of these electrolyte abnormalities. But I've got a list of the symptoms of hypokalemia here, which can present in a patient with primary hyperaldosteronism. The first 3 symptoms are common in both low and raised level of potassium, so that's muscle weakness, palpitations, and lightheadedness. But unique to hypokalemia, we have hypotonia, hyporeflexia, cramps, tetany, and constipation. The other symptoms of primary hyperaldosteronism, aside from hypokalemia, is weakness, which can even lead to quadriparesis, cramps, paresthesias, polyuria, polydipsia, and hypertension in some cases. So whilst we now understand the methods or the pathophysiology of the disease, we need to look at what actually causes it. So first, we have a solitary aldosterone-producing adenoma. This is called Conn syndrome. Then, the most common cause is bilateral adrenocortical hyperplasia. You also have some rarer causes, like adrenal carcinomas and GRA. If you're thinking that a patient may have primary hyperaldosteronism, you're going to want to do some Usinase, renin and aldosterone tests, as well as some adrenal vein sampling. So this is when you take blood samples in order to compare the amount of hormones made by each adrenal gland. Although these patients are often hypokalemic, you don't use potassium values to diagnose this disease, as it isn't always raised or low. If you're thinking GRA, which involves gene fusion, which in turn increases this aldosterone production triggered by ACTH, you should then take a family history and potentially do some genetic testing. Treatment is really condition dependent. If you have a patient with Conn's disease, so we know this is an aldosterone-producing adenoma, you're going to want to do a laparoscopic adrenalectomy. You can also give spironolactone in order to control blood pressure and potassium levels. So remember, spironolactone is a potassium-sparing diuretic, so this increases the potassium, which is good because we know that the potassium is being over-excreted in this disease, so the patients are hypokalemic. For hyperplasia, you would again treat with spironolactone or amiloride. In GRA, you can use dexamethasone in order to normalise the patient's biochemistry, but this doesn't always treat the blood pressure. If the patient is still hypertensive, you can give spironolactone as an alternative. Lastly, if it's caused by an adrenal carcinoma, you need to resect the cancerous lesion and give mitotane as post-operative adenolytic therapy. We've looked into recognising and treating primary hyperaldosteronism, which remember is renin independent, but you can also have secondary hyperaldosteronism. So this means it's not caused by a raised aldosterone level on its own. It's actually mediated by renin. This high renin level is caused by decreased renal perfusion. When renal blood flow is reduced, juxtaglomerular cells convert prorenin to renin. So, anything that affects renal perfusion can cause secondary hyperaldosteronism. So that's things like renal artery stenosis, accelerated hypertension, diuretics, congestive cardiac failure, and hepatic failure. Right. So we have primary hyperaldosteronism, which is renin dependent. We have secondary hyperaldosteronism, which is renin dependent. And the last type is called Bartter syndrome. This is an autosomal recessive congenital condition that leads to salt wasting. It is caused by channel and transporter mutations, which leads to sodium and chloride leak in the loop of Henle. This loss of sodium leads to a volume depletion, causing an increase in renin and aldosterone production. It presents in childhood as failure to thrive, polyuria, polydipsia, potentially normal blood pressure, hypokalemia and metabolic acidosis. In order to treat this illness, you can give potassium replacement, NSAIDs, which inhibit prostaglandins, and ACE inhibitors. Okay. Just to clarify, there are three types of hyperaldosteronism. Primary, which is renin independent and contains Conn's, hyperplasia, and GRA and carcinomas. Secondary, which is renal dependent and caused by poor renal perfusion. And Bartter syndrome, a congenital disease. Now this is a completely separate condition. It's not hyperaldosteronism. This is called a phaeochromocytoma and is instead a catecholamine-producing tumour. Phaeochromocytomas arise from sympathetic paraganglia cells and are collections of chromaffin cells, so these are involved in producing adrenaline and noradrenaline. Usually these cells are found in the adrenal medulla, but they can occur elsewhere. However, extraadrenal tumours are pretty rare. In some cases, these are familial, so family history is really important and you should refer these patients for genetic screening. These are actually associated with cancer syndromes like neurofibromatosis, so you should keep an awareness of this. Phaeos typically present with a classical triad of episodic headaches, sweating, and tachycardia. Although they have this triad of symptoms, there are other adrenergic symptoms they may get, such as hypertension, palpitations, tremor, dizziness, anxiety, diarrhea and vomiting with abdominal pain, and heat intolerance and flushes. The first test you're going to want to do is a 24-hour urine metanephrine test, then do an abdominal CT or MRI or a chromatin-seeking isotope scan. Ultimately, you need to operate on this tumour, but before you do, you give an alpha blocker, such as phenoxybenzamine, rather than a beta blocker, to avoid this unopposed alpha adrenergic stimulation. However, we can give beta blockers in patients that are particularly tachycardic. Then, of course, there's the surgery, and if malignant, you need to give chemotherapy. Right, we've reached the end, so here's the summary. We've looked at hyperaldosteronism as well as phaeochromocytomas, so let's just recap. You can classify hyperaldosteronism in terms of primary, secondary, or Bartters. You should suspect primary hyperaldosteronism if they have symptoms of hypokalemia, paresthesia, and hypertension. Bilateral adrenal hyperplasia and adrenal adenomas, also known as CONS, are the most common causes of primary hyperaldosteronism. Secondary hyperaldosteronism is renin-dependent and is raised due to decreased renal perfusion. Phaeochromocytomas present with a triad of episodic headaches, tachycardia, and sweating, but there may be other adrenergic symptoms. And ultimately, surgery is necessary in patients with Phaeos.